Ma'am, we are live now. With all your permission, I'm starting this session.
Carry on.
Yes, ma'am. Good afternoon, everyone present here. I welcome all the participant doctors on today's session. Let's welcome today's speaker with great honor, Professor Dr. Mathulata Alexander, ma'am. Let me share some of the achievement of the ma'am. Ma'am has done MBBS, MD, Obstetric and Gynecology, and Professor at Osmania Medical College, Hyderabad. Today she is going to discuss on a topic, liver disorders in pregnancy. Let me tell you overview of the topic. Liver disorders in pregnancy can have significant consequences for both mother and the fetus, ranging from mild symptoms to the life-threatening complication. Some of the common liver disorder in pregnancy include intrahepatic cholestasis of pregnancy, ICP, acute fatty liver of pregnancy, AFLP, and Preeclampsia and Sclerosia, and HELLP syndrome, hemolysis elevated liver enzymes, low platelet count. To know more about this topic, I would like to invite ma'am and hand over this session to you. Over to you, ma'am. Kindly proceed from here.
Thank you so much, Faraz, for the introduction. I'll just share my screen. Now, liver disorders in pregnancy is something what we obstetricians, we deal with them day in and day out. And I, being in the public sector, we have quite a few serious patients because they are referred to us from the periphery. In the next few slides, I would like to highlight what problems we have, and I would like to give you the latest updates on this topic, which has always fascinated obstetricians, and it's also a mystery sometimes. As I carry on, you will realize. Now, what happens to the liver during normal pregnancy? Now, the diagnostic evaluation is similar to the evaluation of the non-pregnant patient, okay? We have to evaluate the liver the same way as the non-pregnant lady does it. It includes the history, physical examination, laboratory studies, and also a liver ultrasound. Now, the liver may be displaced upward as the gravid uterus enlarges, and usually in pregnancy, the liver is not typically palpable. Now, Palmer erythema and spider angiomas, we are all used to all this. We see them only in chronic liver disease or in older people where the estrogen level is more. This can be a normal phenomenon of normal pregnancy because of the increase in estrogens. It usually subsides after delivery. Now, what are the normal physiological changes in the laboratory tests during pregnancy? If you look at all the various parameters regarding the liver functions, the transaminases, the AST and ALT, there's no change, and also the bilirubin and the prothrombin time and the INR. The serum albumin decreases mainly because of the hemodilution of pregnancy. And alkaline phosphatase increases, but not more than 2 times the normal. The hemoglobin decreases, as you all know. Otherwise, the GGT and the 5-nucleotidase does not change during pregnancy. Now, these are all the normal reference ranges, what we see in pregnancy. And as you can see, the bile acids, what we will be dealing later, last part, the bile acids, this is what we deal with in the IHP, intrahepatic cholestasis of pregnancy. This does not increase during pregnancy in the normal way. Now, there are various pregnancy-related liver disorders. One, the diseases that are unique to pregnancy, which I will be discussing today. My talk will be limited to the primary liver diseases, like this IHCP, intrahepatic cholestasis of pregnancy, the AFLP, that is the acute fatty liver of pregnancy, and also the systemic disease with hepatic manifestations, that is the preeclampsia with severe features and hyperemesis gravidarum. My talk today will be restricted only to these topics. The other diseases that are exacerbated by pregnancy, that is the gallstones and the valvular diseases, and the diseases that are related to but are coincidental to pregnancy, that is viral hepatitis. This requires, I think, many more sessions to go through. So my talk will be limited to this topic. What are the indications of the liver function test and when do you order them? Any liver disease in previous pregnancy, yes, you have to order the LFTs. Chronic hypertension or gestational hypertension, or if there's any risk for liver disease, that is metabolic syndrome or alcoholic use. And any viral hepatitis identified on prenatal screening. Example, if the patient is HPSAD positive, or anti-HCV positive. All these require LFTs. And the basic test, what we have to be ordered is the transaminases, the alkaline phosphatase, the bilirubin, the prothrombin with the INR, and the serum albumin. Now, these 4 topics which I'll discuss today, the first trimester, usually only hyperemesis gravidarum is there. And the other 3 topics, that is IHCP, the HELLP, and the AFLP, and hepatic rupture will come only the 2nd and 3rd trimester. Now, the first topic which I'm going to discuss in detail will be hyperemesis gravidarum. What is this? It is not the usual nausea and vomiting of pregnancy. It is a severe form of nausea and vomiting, and it's about 0.3–3.6% of pregnancies. It is reported in these pregnancies. Now, why do we get this? There are various causes. Probably the most important is that it may be starvation injury, or it may be placental releases of inflammatory cytokines, or there may be an impairment of fatty acid oxidation. Exactly why it comes only in some pregnancies, why it comes only in few people is still a mystery. When we talk about hyperemesis, it refers to a triad of 5% pre-pregnancy loss, the weight loss, dehydration, and electrolyte imbalance. The ultrasound is one of the first things that we have to do. We have to confirm the viability of the fetus and explore multiple pregnancy or gestational trophoblastic disease, in which conditions we know hyperemesis may be more common. Now, in the basic evaluation, we have to look for the urine analysis. Ketones may be positive because of the starvation, electrolyte imbalance because of the severe vomiting, hyponatremia, hypokalemia, and hypochloremic acidosis, the liver function test, and the creatinine, which helps us to distinguish between the pre-renal or the renal failure. Now, basically, most of these conditions we have to deal with in the outpatient. What do? Stop all medications that aggravate nausea, okay? Reassurance and support should be given to the mother, to the patient. This is very, very important because, as we know, this has a strong psychological connection. Oral hydration and dietary advice is also needed. And usually it subsides with doxylamine succinate, the usual one what we use, and pyridoxine. Now, to come up, everything has a score nowadays. And to classify the severity of this, we have a PUQE score. That's a pregnancy unit quantification of emesis score. It's an objective and validated measure for the severity of nausea and vomiting. It has been described in the Green Top guidelines in 2016. I put up this score just for reference, and they have asked certain questions like in the last 24 hours, how many times you felt nauseated, etc. This can be done by anyone, including the ANM or the nurse in the OPD. And when you get a scoring, you give each one a score, and up to 7 to 12 is okay, the mild and moderate. But generally, when we go to the severe score, that is 13 to 15, it is the most severe one that has to be hospitalized. Now, how do you manage these people, the hyperemesis? Now, first you have to do the score, address the clinical complications. Is there dehydration or not? And as I will keep repeating, we have to exclude other causes of this problem. Now, if the score is between 3 to 12 with no ketonuria, antiemetics, simple ones, and dietary changes will do the trick. But if the score is more than 13 with no ketonuria, we can manage with ambulatory daycare management. But here we have to go to the second line antiemetics, that is the ondansetron, etc., and parenteral hydration. Now, any score which is more than that, any score from 3 to 13 which has got ketonuria, you have to manage inpatient. You have to go to second line of antiemetics and maybe steroids, rehydration, and sometimes thromboprophylaxis has to be considered. How do you manage the patient inpatient? Nil per oral. Patient should be absolutely nil. IV lifeline should be there. The vitals should be monitored, and the intake output chart should be maintained strictly. And the nurses should inform the doctors if the pulse goes more than 120 per minute or the urine output is less than 60 ml in 24 hours. What they give is usually the multivitamin, thiamine supplementation, IV, KCL based on serum electrolyte levels, and the second line of antiemetics, the ondansetron, metoclopramide, and the promethazine. Fluid correction is done by the ringer lactate and normal saline, and we should avoid dextrose infusions because it can precipitate thiamine deficiency. The hypovolemia to correct, we give 2 liters over 3 to 5 hours, and it has to be maintained at about 2 ml per kg per hour. Now, sometimes, in spite of this, the cases are refractory. You have to complete the evaluation, look at LFT, look at the thyroid. It may be a manifestation of thyrotoxicosis. Amylase and lipase, it may be pancreatitis. Do a blood gas, rule out metabolic disturbances and to monitor severity. Rule out other causes, and you have to take the obstetric medicine team opinion should be done. The endoscopy will rule out any hiatus hernia with erosive esophagitis. How do you treat it? By intravenous hydrocort, 100 mg 12 hourly for every 3 days. Vomitings will be controlled. Once the vomitings are controlled, switch to oral tablets, and you have to continue maintain with the H2 receptor antagonist, because you have to continue to treat or prevent the esophageal reflux. Now, the next important topic which I will be covering will be the intrahepatic cholestasis of pregnancy, which is a little more dangerous one. The incidence is about 0.2 to 2% worldwide, and it's about 2 times as common in Asian women as compared with white European women. There is intensive pruritus. That's why I put this picture up. Basically, it covers the palms and soles. The exact explanation is not known, and mainly in the night. And usually this comes in the 3rd trimester in 80% of women. However, in this condition, jaundice is rare, affecting only less than 10% of women with intrahepatic cholestasis of pregnancy. And in this condition, there's an increase in the total amount of bile acids. What is the etiology? Now, about 10 to 15% of cases, probably by known genetic variation. It usually comes with multifetal pregnancy. I think in every factor, you have to put this multifetal pregnancy, following in vitro fertilization or in older women. It also comes in history of gallstones or hepatitis C infections. And sometimes it has been precipitated after oral progesterone treatment to prevent preterm labor. Many times we give this treatment. Once I have seen a case where this ICP has been precipitated with this oral progesterone. Sisters of affected women also seem to be more common, probably by the genetic component. I have put up this picture. It's a very nice picture, which you can use it as a flow chart, how to manage patients with pruritus. But these patients should not have a rash, because rash has other implications. The first thing what we do is we have to do the serum bile acids and the LFTs. Now you have 3 groups, the group A, the group B, and the group C. Now in the group A, the bile acids and the transaminases are normal. Now in these patients, if they continue to be normal, you keep repeating them. But if any time the bile acids, if the transaminases are increased, you manage to go to group B, or if any time the bile acids are increased, you go to group C. Now when the transaminases are raised, look for other causes, that is the preeclampsia, AFLP, and HELLP. Look for it, because it doesn't usually rise in the normal circumstances. Repeat the LFT and the bile acids. If it's normal, continue as above. And if it is raised, the bile acids are raised, immediately switch to group C. Now, group C also, when it is both are raised, look for other causes. I'm repeating myself. If the above is negative, if these causes are negative, then you diagnose intrahepatic cholestasis of pregnancy. And in this, first line treatment is the ursodeoxycholic acid, 500 milligrams twice daily, and repeat the bile acids and LFT, and I'll tell you how to manage them in the next few slides. Now, this bile acids levels has a very predictive value of maternal outcome. It is a serum bile acid is the most sensitive and specific marker for the diagnosis and monitoring of this ICP. Now, usually bile acids are not done in the routine LFTs. They are done only in specified labs. So we have to find out. It is expensive. It is done in the place where I work, but we have to find out and send. Another problem of this is in the fasting stage, I believe bile acids are at a lower level. So this may change the monitoring and may change the management. But all this should be kept in mind when we are managing these cases of ICP. But the main thing why we as obstetricians are concerned is the incidence of stillbirth after 37 weeks becomes 1.2. And they have found that if it's more than 40 micromole per liter, the risk of fetal complications increases. That is spontaneous preterm birth, fetal distress, etc. And the stillbirth rate increases by 10 to 15% when it becomes more than 100 micromoles. So this about 40 micromoles per liter. We must be very careful and very cautious, and how to manage the baby. Now, how do you treat these patients with this ursodeoxycholic acid? The exact mechanism is not understood. It decreases the level of bile acids in the maternal and umbilical called serum, and it also causes qualitative changes. Although it is not licensed for use in pregnancy, it is widely used throughout the world with no known teratogenicity. You can go up to 2 grams per day in divided doses. In spite of it, many patients don't respond. So then you have to go to second line, that is rifampicin. Now, there's a lot of experience they had with rifampicin when treating primary biliary stenosis. When you have a lot of pruritus, and they've combined this with this urodeoxycholic acid, and they have decreased it. So, and also there's a study done in 2015 when they've combined rifampicin and UDCA, and they have found out that about 50% of the decrease in 50% of serum bile acids and 50% of the women treated. So a combination may be helpful. Apart from this, adjuncts to therapy are antihistamines, such as chlorpheniramine maleate, and topical agents, such as aqueous cream, may be useful. Now, antihistamines, exactly, they do not improve the pruritus, but they may be offered to improve sleep and probably give symptomatic relief to the patient. The mode of delivery is individualized. Spontaneous onset of labor or induction, if you do both ways, there is no difference in the emergency section rates and no problem with the regional anesthesia with ICP. Postnatal, we have to check the liver functions and serum bile acids 6 weeks postpartum. And if they remain high, look for alternative causes for hepatic dysfunction. Referral to a hepatologist should be considered. And they say up to 90% recurrent risk is there. But this risk is lower if the index pregnancy was multifetal. And also the symptoms of this have also recurred with OC pills, with estrogen progesterone combination. Therefore, patients who had ICP, and if you are starting on oral pills, think of alternative methods of contraception. The other common problem that we all as obstetricians face day in and day out is HELLP. Now, it occurs in about 0.1 to 1% of pregnancies, and I'll be dealing with this only because it has a liver implication. And the total bilirubin level increases as a result in the indirect or the unconjugated fraction from hemolysis and LDH. And better is the serum haptoglobulin, which is a better indication of hemolytic anemia. Birth eventually leads to resolution of signs and symptoms of HELLP. Now, is HELLP separate from preeclampsia? Yes, it seems to be, because in HELLP, antecedent hypertension or proteinuria is seen only in 85% of cases, unlike preeclampsia, where 100% of patients have this. 15 to 20% do not have this hypertension or proteinuria. And liver dysfunction is very pronounced in HELLP, not in preeclampsia. And this does not, the magnitude of the hypertension does not correlate with the angiopathy and liver dysfunction in HELLP. Thrombocytopenia and liver dysfunction is very severe in HELLP, not so severe in preeclampsia. And the hypertension is very high in preeclampsia usually. What are the risk factors? Previous history of preeclampsia or HELLP is the immediate risk factor. A variety of genetic variants are associated, but there's no point in testing them because they have no role in clinical management. Nulliparity is not a risk factor for HELLP, because unlike preeclampsia, where nulliparity is a risk factor, and multiparous patients account for more than 50% of HELLP patients. Now, if you look at the pathophysiology, it is microangiopathy and activation of intravascular coagulation. You can see the fibrin deposition in the picture on the right with neutrophilic infiltrate and lobular necrosis and periportal hemorrhage. All these spots, you can see the periportal hemorrhage. Now, there's a classification to diagnose HELLP. Now, if you diagnose HELLP, all the 3 parameters must be there. That is the hemolysis, elevated liver enzymes, and low platelet count. If only 2 are there, we call them as partial HELLP, but treatment basically remains the same. For hemolysis, at least 2 of the right factors should be there. abnormal peripheral sphere, LDH, bilirubin, and low serum haptoglobulin, and severe anemia unrelated to blood loss. Elevated liver enzymes and low platelet count is also necessary. This is the Tennessee classification, what is being currently used nowadays. Now, what happens? What is the most frequent signs and symptoms of HELLP syndrome? This is taken from the recent up-to-date. And the right upper quadrant or epigastric pain, 40 to 90% of people are having this right upper quadrant pain. So whenever a patient comes to us with this problem, we have to be very alert, even if other parameters are and blood lab parameters are normal. Proteinuria and hypertension are also there. But the one that is in HELLP, what we are concerned about is the pain. Now, this pain may precede the laboratory abnormalities by several hours. Therefore, if a patient is complaining of pain, keep repeating the laboratory tests every 4 to 6 hours, unless another cause for the pain has been determined. The other ones are the usual ones, what we do for the preeclampsia profile: urine examination, urine culture, uric acid, etc. Haptoglobulin, LDH, and coagulation studies also have to be done and cannot be missed. Now, if you look at the liver HELLP, all those periportal hemorrhages, they can correct together and they become a liver hematoma, and then it becomes a subcapsular hematoma, which is seen here in the MRI report. Compared to an ultrasound, a CT or MRI is a better indication of a hepatic hepatoma and rupture. If you take all patients with HELLP, very few have got this liver hepatic, the hepatoma. But if you take patients who have had imaging, 45% of them are having this subcapsular hematoma and intraparental hemorrhage. Can I repeat myself? If you take all patients with HELLP, very few of them seem to have this. But if you take patients who have had imaging studies, 45% of them have had this involvement of this hematoma. Now, if you look at the delivery in hypertensive disorders, we are all very familiar with. Chronic hypertension, gestational hypertension, and preeclampsia without features deliver at 37 weeks, with features deliver at 34 weeks. But if you look at the latest recommendations, this is an indication to deliver the mother irrespective of gestational age after maternal stabilization. HELLP syndrome is one of the main indications. How do you manage HELLP? Stabilize those who are unstable, assess the fetal status, and it should be managed at a tertiary care center where appropriate levels of maternal and neonatal intensive care are available. In Telangana, we have a very excellent referral system. So any case is referred immediately to the next higher center without any delay, and all cases are followed up very carefully thanks to Telangana government. Now, how do you choose the route of birth? Vaginal birth is the desirable route in the absence of any standard indications for cesarean birth. And if the cervix is favorable, induce patients with HELLP regardless of gestational age. If the cervix is unfavorable, and if the gestational age less than 30 to 32, probably the first line of management will be a cesarean birth. Is there any role for dexamethasone in the treatment of HELLP? Treat patients with HELLP. This was very common and a few years ago, but now the two largest randomized double-blinded placebo-controlled trials have said there is no role for treatment with HELLP with dexamethasone. It can only be used for lung maturity, but of course the maternal disease takes precedence, and you should not waste time for lung maturity if the mother's condition is deteriorating. Now, the last condition what I'll be discussing is the acute fatty liver of pregnancy, which is probably the most dangerous and the most fulminant. It is an obstetric emergency. It commonly occurs in the third trimester, and it's the most common cause of acute liver failure in pregnancy. But improvement because of earlier diagnosis, prompt delivery, and advances in critical care, the mortality rates have decreased from more than 75% to less than 5%. It is a multi-systemic involvement, including acute injury, kidney injury, encephalopathy, coagulopathy, pancreatitis, pulmonary edema, and adult respiratory distress syndrome. It is also a diagnosis of exclusion. What about the epidemiology? It occurs in about 1 to 7,000 to 20,000 pregnancies. And the potential risk factors for AFLP are the LCHAD, long chain 3-hydroxy acyl dehydrogenase deficiency. This is a very critical enzyme in the mitochondrial fatty acid metabolism. It's responsible for 20% of cases of AFLP. Any prior episode of AFLP, multiple gestation, hypertension. In this condition, only 50% of these cases have got hypertension. Okay, male fetal sex and low body mass index also seems to play a role, and nulliparity. Now, if you look at the pathogenesis, it's the defective metabolism. That is, if you look at the mitochondria where fatty acid metabolism is going on, this enzyme here is defective. Therefore, the intermediate metabolites keeps increasing. It accumulates in the maternal blood and hepatocytes and has a deleterious effects on maternal hepatocytes. It involves a multisystemic involvement, and a kidney injury may be primary or maybe usually because of hepatorenal syndrome, encephalopathy because of the uremia, coagulopathy, pancreatitis, pulmonary edema, and adult respiratory distress syndrome. This is a typical histopath. We all are very familiar with this picture, where there's a microvesicular fatty infiltration, or it's called a microvesicular fatty steatosis of pregnancy. Complications I've already listed, and they can be surgical and obstetrical hemorrhage, acute liver failure, acute liver kidney injury, and encephalopathy. There is a criteria for AFLP. That is, they have this Swansea has done some criteria. There are signs of symptoms: vomiting, abdominal pain, polydipsia, polyuria, encephalopathy, imaging, and all the laboratory findings: elevated bilirubin, hypoglycemia. This is because the liver is, of course, involved with the regulation of gluconeogenesis. When this decreases, there will be hypoglycemia, leukocytosis, elevated enzymes, ammonia, etc., and coagulopathy. Now, what they have found out is about 6 or maybe 9. If any of these criteria are positive, it is considered as AFLP. Research says it is 9 criteria. There's still a debate about it. How do you manage it? Prompt induction of labor and delivery is the mainstay or the cornerstone of management. Maternal status has to be optimized, and labor induction is a reasonable option when the standard tests of fetal well-being are reassuring, the disease is not rapidly progressing, and if you think vaginal birth is likely to be accomplished within 24 hours. You may think of fetal status and giving neuroprophylaxis with Maxalf, but mother's condition takes precedence. This is a nightmare for anesthetists because of the labor analgesia dependent on the hematological values. There is hemodynamic instability, ongoing fluid replacement, which confuses the issue. You have to correct the coagulopathy, administrative uterotonics, and cerebrovasodilators. All this gives our poor anesthetists nightmares. Postpartum management. Usually this problem resolves completely after delivery with return of normal liver function within 7 to 10 days. And a transient worsening of liver and renal functions with coagulopathy, peripartum, has been reported. So we have to continue the monitoring following delivery. That's why you have to transfer these patients to higher centers. And the limited data available suggests there is no sequelae of the liver disease itself. Now, what about the recurrence and subsequent pregnancies? It has been reported, even if the deficiency mutation is negative, but the exact risk is unknown. What about perinatal outcome? Children born to mothers with AFLP should be monitored for manifestations of LCHAD deficiency, especially hypoglycemia. Now, even in early childhood and neonatal period, keep monitoring the children, especially if they have a viral disease or dehydration. They can manifest with this disease. Molecular testing is necessary, and early diagnosis can be life-saving in the newborn. Tests should be done in coordination with a metabolic or a genetic specialist. And if a newborn is positive, check the mother, check the father. And if they are positive, family screening is necessary. What is the additional intensive care management? Combining therapeutic plasma exchange with continuous renal replacement therapy may be an option for patients with ongoing progressive disease despite delivery. This is called bridging therapy. That is, you have to do this therapy, but the mainstay of this will be liver transplantation with acute liver failure. You should have a multidisciplinary team transfer to a higher center where the liver transplant service can be there. An aggressive fetal fluid replacement is needed, but you must be careful because the low plasmatic oncotic pressure can lead to pulmonary edema, which can lead to death. This is a very good slide what I have put up, which should be in all labor rooms. That is, any patient with gastrointestinal symptoms in the third trimester, these could be the differentials. All these. Now, if the patient has liver disease, there are all plus and minus signs. Plus says either the liver functions are the factor is there or increasing. Negative means factor is not there or factor is normal. If you put this easily, you can put your patient in whichever compartment. But also one more thing I must say is there a lot of overlap in this. So exact diagnosis may not be important. But what the cornerstone of treatment is, apart from hyperemesis, all the other dangerous conditions, delivery is the treatment. The take-home message is, as I said, it may not be possible to distinguish between the AFLP, HELLP syndrome, and preeclampsia with severe features. The clinical management is the same, prompt delivery. Patients may have both with severe features. Hypertension is not a very important factor because only in preeclampsia 100% have it, HELLP 85%, and AFLP only 50% have it. If there is multi-organ involvement, especially concurrent renal failure, hypoglycemia, encephalopathy, and ascites and coagulopathy, think more it is AFLP rather than HELLP. In addition, non-pregnancy related causes of abnormal liver chemistries needs to be assessed. Thank you.
Thank you so much, ma'am, for your precious time and sharing your knowledge with us and making this session an informative one. I definitely think this session knowledge is going to help all the participants who have joined this session. Ma'am, we have received some question. If you allow, can I take this question with all your permission?
Yeah, sure. Go ahead.
Yeah, ma'am. The first question I can see is what liver disorder are specific for pregnancy?
All these four what I discussed, the hyperemesis, the intrahepatic cholestasis, HELLP, and the AFLP, all these are specific to pregnancy. All the other things what I put up in that slide, they can be overlapping, but these four are unique to pregnancy, which I discussed.
Okay, thank you so much, ma'am, for explaining it. Moving forward, I can see another question, second question from the question is elaborate pre-eclamptic liver dysfunction.
Pre-eclamptic liver dysfunction.
Yeah, right, ma'am.
Yeah. See, now the liver dysfunction that is specific to eclampsia is HELLP, what we are worried about. Okay. HELLP is HELLP, that's the one that comes with liver disease. The other thing is, I've already discussed, it comes with liver disease. AFLP and all are, each of them are unique. They may be overlapping of all these conditions, but the specific condition with hypertension is HELP. I hope this answers your question.
Okay, thank you so much, ma'am, for explaining this question. Ma'am, we will be taking last question. I can see there is one last question for today's session. And the question is, what is interpretation of liver function test during pregnancy? Interpretation.
Actually, I put up a good slide. If you want, I can share it with you all. So certain things are normal. That is, I told you, certain the transaminases, most of the liver functions are normal. The alpha fetoprotein decreases because of the hemodilution. The alkaline phosphatase increases. All these are available at reference sites and should be there in all labor rooms for us to have a reference range. Okay.
Yes, ma'am. Okay, ma'am. Thank you so much, ma'am. I can see there is no more question from the participant, and I hope you are able to clear all the dots related to this topic, ma'am. It was a really wonderful session from your end. As there is no more question, shall we conclude this session with all your permission?
Yeah, thank you.
Okay, ma'am. Thank you so much, ma'am. Until then, take care of yourself and hope to see you again with different topic. And that's it, ma'am, for today. And have a great day.